Hello, and welcome to the College of American Pathologists live stream discussion on colorectal cancer in younger adults. I'm Dr. Donald Karcher, President of the College of American Pathologists. Before we get started, I'd like to explain a little bit about who pathologists are and what we do. A pathologist is a physician who diagnoses disease and leads medical laboratories. We make diagnoses by examining tissue, blood, and other specimens taken from patients. Biopsies your doctor performs in his or her office, larger tissue specimens removed during surgery in the hospital, and blood and other fluids removed for diagnosis are examined by a pathologist using a microscope and many more sophisticated laboratory techniques to determine what the diagnosis is. These diagnoses could be cancer, inflammatory disorders, or many other possibilities. Pathologists also lead medical laboratories. Whenever you have a blood or other specimen collected as part of an evaluation by your doctor or other healthcare professional, that specimen is almost always sent to a medical laboratory. Pathologists lead these laboratories and ensure the test results are accurate and available quickly. As you can see, pathologists touch almost every part of medicine. Although you may not see us, or even know about our work on your specimen, we're there providing answers to your doctor that will be used in your treatment. March is National Colorectal Cancer Awareness Month. Today, we're focusing on the rise of colorectal cancer rates in younger adult population. Joining me for today's discussion are Dr. Adam Booth, a gastrointestinal pathologist, and Dr. Judy True, a gastroenterologist. Dr. Booth, can you please introduce yourself and tell us a little bit about your role as a gastrointestinal pathologist?
Sure. Thank you, Dr. Karcher. So I'm Dr. Adam Booth, and as you mentioned, I'm a gastrointestinal pathologist. The simplest way, the way I like to describe it to patients is, when you go get a colonoscopy, if the gastroenterologist, takes a bit of that tissue or they take a polyp, that polyp goes through several stages of processing, and I look at that polyp under the microscope, and I make a diagnosis of, maybe that's cancer, maybe it's not cancer, maybe it's just an inflammatory polyp or something like that. So I really evaluate that and make a diagnosis under the microscope and send that back to the gastroenterologist.
Great. Thanks, Dr. Booth. Dr. True, please introduce yourself to our audience and explain your role as a gastroenterologist.
Thank you, Dr. Karcher. It's great to be here today to talk about such an important topic. I am a gastroenterologist, so patients will see me in clinic or more commonly in procedures. So I perform colonoscopies with a specific focus on actually removing larger polyps, and these polyps are larger that may prevent a patient from getting a big surgery. So that's what I typically focus on.
Great, thanks, and welcome to both of you. If our viewers have any questions for our panelists, please, during the discussion, please ask in the chat function. So let's get started with our discussion. Here are a couple of facts. Today, according to the Centers for Disease Control, colorectal cancer is the deadliest cancer for men under age 50, and the second deadliest cancer among women in the same age group, behind breast cancer. According to the American Cancer Society, the risk of developing colorectal cancer is about 1 in 23 for men and 1 in 25 for women. Genetic, environmental, and lifestyle factors can affect your risk for colorectal cancer. The actor Chadwick Boseman died a few years ago from colon cancer. Baseball great Darryl Strawberry fought colon cancer twice and won. The Jonas Brothers have a family history of colon cancer, as their father was diagnosed with stage 2 colon cancer at age 52. Those statistics and those who have died and fought this disease at a young age are startling. Why do you think that is, Dr. Booth, Dr. True?
Well, we actually don't know why this trend is rising, but researchers are looking into how lifestyle factors are increasing this trend, such as the rise in obesity, the rise in eating processed foods, as well as lack of exercise. We're also looking at the role of alcohol and tobacco as well.
Great, yes. And I suspect there may be some other factors that we haven't even thought of yet. So, more facts. The 3 leading national gastroenterology societies formed a task force that led in 2021 to dropping the recommended age to begin screening for colon cancer from 50 to 45. This is for people with an average risk versus someone with a family history of colon cancer, certain underlying diseases involving the colon, or symptoms suggesting possible colon cancer. Dr. Booth, why is screening for colon cancer so important?
Well, thank you, Dr. Karcher. Screening is the only way to really prevent colon cancer at this point. So in order to catch those polyps either before they become cancer or right as they are becoming cancer, colonoscopy is the only real way to achieve that. So to go in and actually take out those polyps and kind of pluck them out, if you will.
Yeah.
So, but it's important though, because screening catches things before you develop symptoms. And so before you develop maybe more advanced disease. So that's why it's critical to be screened, and take these recommendations seriously, for example, like 45 years old versus 50, so that you can get screened, because that's how, through data and research, they come up with this information, the age range and guidelines for when you should be screened or not. So based on a lot of evidence and data. So it's important to do that so that it's important to be screened. So if we're saying at 45, so that, because that's when everything shows that we should catch most of those colon cancers or prevent those colon cancers from developing.
Yep. And we've used the word polyp quite a bit so far. And so just so for our audience to know, polyps really are growths on the lining of your colon that have the potential to turn into cancer. And that's what Dr. Booth was saying, is that these colonoscopies not only can find cancer, but really prevent cancer too. And once during a colonoscopy, I detect these polyps or I see these growths, I can fully remove them so that it's no longer a risk to you. And once I remove these polyps, I send it over to Dr. Booth for him to look under the microscope.
And when I look at that under the microscope, I'm looking at different features that I might see. So, that looks at the pattern overall of the tissue. And remember, I'm looking under the microscope, I'm looking at the cells that are just a few microns thick. So very small, right? So, I'm looking at the cells themselves, the nuclei of the cells, so the center of the cells, kind of where the genetic information is at. Looking at the different features of the cells to determine, whether or not they may be precancerous or cancerous already.
Great, very helpful. Dr. True, you mentioned risk a moment ago. Can you explain further average risk versus someone being at a higher risk for colon cancer?
Sure. And this is such a great question because it's so important to our patients to know this. And so let's start with higher risk. So patients with higher risk of colon cancer are patients with a family history of colon cancer, and also patients with a family history of advanced polyps. And so the term advanced polyps may not be as common, or they may not know as much, but really just ask your family members if they've ever had a colonoscopy, if they've had polyps before. That might be the easiest way. And also, I really love having our primary care physicians and also, gastroenterologists to be involved in this determination to help patients figure out whether or not they are at higher risk. So the two main factors is family history and a family history of advanced polyps. And so the patients with that will be at higher risk. And then we talk about average risk. So average risk patients are patients without a family history of colon cancer and patients without a family history of advanced polyps.
Thanks for explaining that. Dr. Booth mentioned earlier about, catching colon cancer before symptoms. So let's talk about symptoms, because as we know, they can be very subtle or maybe not even occur at first. So Dr. True, can you talk about colon cancer symptoms and what needs to be on people's radar?
Sure. So the scary part is actually majority of patients don't get symptoms. And so that's why it's so important to get these screening tests before they develop symptoms. having symptoms actually may indicate that the colon cancer is either present or in advanced stages. And so things to look for and things to pay attention to is, number one, blood in the stool. So having bloody bowel movements, that's the first common symptom, if there are symptoms at all. The next is changes in bowel habits. We ask our patients that a lot. Are you having more frequent diarrhea or more frequent constipation? So changes in your regular bowel habits may actually indicate something's going on. Other symptoms one may have is incomplete evacuation. So basically when you're having a bowel movement and you feel like you're not fully emptying, ongoing abdominal pain, as well as losing weight when you're not intentionally trying to too. And so those are some common symptoms of if someone may have colon cancer. Not all of these symptoms mean that you have colon cancer, but I think these are really important in order to bring up to your primary care, which I know can be sometimes difficult to bring up.
Yeah, some of those issues can be a little bit sensitive for people, or you maybe don't want to talk about. I think it's important for patients to remember, that doctors and primary care physicians are all professionals. And so, and that's what you're here to talk about those things with us, so when they come to you, so you expect them to talk about their bowel movements and how that's going and if they're having any problems with that. So, getting over that, kind of sensitivity of that area is an issue.
Yeah. Oh, absolutely. I get pictures from patients about their, stooling and pictures from the toilet all the time. So I welcome it in my field. Like, we really want patients to feel comfortable and just really talk to us about what's going on, because that's the only way we can help them.
Yeah, that's very helpful. And as you said, most patients with colon cancer don't have symptoms, but sometimes they do. And there have been studies to show which ones are the ones to worry about more. In August of last year, a study by the National Cancer Institute showed in the period between 3 months and 2 years before a patient was diagnosed with colon cancer, the following 4 symptoms were most commonly reported in people who developed the cancer: abdominal pain, rectal bleeding, diarrhea, and symptoms of iron deficiency. I'm a hematopathologist, which means I diagnose diseases of the blood, including anemia. Patients with colon cancer can bleed and sometimes not even notice it, particularly if that cancer is higher in the colon. Bleeding like this can deplete iron stores in the body, leading to iron deficiency. Having just one of these symptoms during this period of 3 months to 2 years was associated with nearly twice the likelihood of being diagnosed with early onset colorectal cancer compared to having none of these symptoms. And having 3 or more of these symptoms was associated with a 6 times likelihood of being diagnosed with the disease. So it's very important to pay attention to these types of symptoms. These findings, by the way, were published last year in the Journal of the National Cancer Institute. So you have these symptoms. What comes next? Dr. Booth, what do you think?
Well, if you're having these symptoms, colonoscopy is really the only option. So they need to, go in there with the camera and the hose and the tube, and you need to go through the whole process. But that's the only way to identify and hopefully prevent or catch that, whatever's causing those symptoms early on, ideally. But the symptoms, again, that's the important part of really trying to, listen to your body and communicate that to your physician, so that, when you're not quite feeling right, because sometimes, maybe just not quite right. And so, kind of listen to yourself, trust yourself when you don't feel quite right. Maybe when you have a cold coming on, you kind of have that itchy feeling. So just, try not to let the busyness of life, especially hectic stuff going on with work and everything, cause you to put the stuff in the back of your mind, whenever maybe you do have that, you're losing weight and you weren't really trying to, or maybe you do see some blood in the toilet, so try not to put that stuff to the side, whenever life is too busy and everything. Listen to yourself and talk to your physician, your primary care physician, or your gastroenterologist that, this is, it's not quite right. You've been living with yourself daily for decades, so so you have an idea. Dr. True?
I agree with that. That especially with having symptoms at that point, it's really a colonoscopy really is the next step. For patients without symptoms, then we have other options, but a colonoscopy definitely would be the next step if you do have these types of symptoms. Talk to your primary care. That's the biggest thing. Usually they're the first step, and so you talk to your primary care. Let them know the symptoms that you're having, and that way they can direct you to the right next step, whether it's to come see me in clinic or to do a colonoscopy and doing a procedure with me.
Great. That's great advice. How important is it to prepare for a colonoscopy? We know it's not easy, but we all know the cleaner the colon, the better the results, right? Dr. True?
Absolutely. The bowel preparation is the most important part of the colonoscopy, and it's a lot of hard work. So I make it a habit to congratulate the patient right before the procedure and say thank you for doing this prep and congratulations for getting through it, because it's not easy, but it helps my job a lot easier to help you, essentially. So basically the cleaner the walls I can see, the more of the walls I can see, I can really pick up smaller polyps, these smaller growths that could have the potential to turn into cancer down the line. If I can see them, especially those, less than 5 millimeters, very tiny, if I can remove them, then it's no longer a risk. So the cleaner the bowel prep, the better. And each person's different, so we have our certain standard medications that we give patients to clean out their bowels. They can follow the instructions to the T, and they may not be completely cleaned out. And that's because each colon is different. And so talk to your primary care doctor about the different bowel preps as well. There's the larger jugs of bowel preps that's more difficult to handle, but we have the best evidence for them. But of course, there are definitely other options that are more tolerable for patients too. And then talk to your gastroenterologist or your primary care about ways to really decrease, or I guess ways to make it a little bit easier too. I usually like recommending to my patients like the lemon flavoring. A lot of them like doing that, drinking through a straw actually, and then keeping the prep cold. So that usually these are little tips that can help drink the prep a little bit easier.
Great, thank you. So now you've had a colonoscopy and a polyp was found. As a pathologist, what are you looking for, Dr. Booth, when you receive a specimen of a polyp?
Thanks, Dr. Carter. As I mentioned earlier, I'll receive this polyp, and what I see is I get a sliver, a slice of that on a glass slide that's been stained, and I look at that in the microscope. And so what I'm looking for is different features in those cells to determine whether or not I think that they're like precancerous, or I think they're, maybe just kind of, we'll say, unhappy. Maybe something passed them in the colon and it just irritated that tissue there. But I'm looking at that, and so I look for any for unnatural growth or the cells kind of growing out of control. So that's what cancer really is. It's out of control cell growth. And so I'm looking for that. I look for cells that kind of almost look the same exactly. They're larger and they're darker, meaner looking, we'll say even. So I look for those features, but I also look at the number of polyps that maybe you see. So that's very important. And I know Dr. Shu's going to touch on that. But I also look at, so if I do see some of those more concerning features in that polyp, I look for the extent of those features. So there's different kind of degrees of dysplasia. So that's kind of precancerous. And so there's a low and a high grade and then all the way to cancer. And so I look at where that polyp may fall on that realm. And then I've categorized that. And I'll convey that to the gastroenterologist, and that's going to help really, dictate the next steps for the patient. So, whether or not I say that there was 3, adenomatous polyps versus 1 versus 12, that's going to change when that patient is being screened again. Like Dr. Shrew?
Yeah. Oh, absolutely. So, we talk about getting your first screening colonoscopy, your first colonoscopy, and that will determine, whether what I find on there and what Dr. Booth also sees under the microscope, that'll determine your next colonoscopy. If I find 0 polyps, then we can go as far as 10 years for your next colonoscopy, which is great, especially if I am able to see all the walls clearly. But if Dr. Booth under the microscope sees different types of polyps, or polyps that are precancerous or have changes towards cancer, I may have to bring you back sooner rather than later. Not because, and I always say this to my patients, not because you're doing anything wrong that's causing these polyps. It's a combination of genetics, bad luck, and just, we're just trying our best to prevent colon cancer with these colonoscopies.
Great. Very helpful to understand how you both view how we deal with polyps. So, Dr. True, how can a young adult be their own advocate? Many younger adults may not get a yearly physical or have a job that provides health insurance. What should a young adult do to be looking out for their best interests?
Oh, absolutely. So, in healthcare, we actually term this group of patients called the young invincibles. It's usually, the group of patients who have just gotten off of their parents' health insurance and feel so young and healthy, and they feel like, oh, nothing's ever going to happen to me, and that's actually the scariest portion of our population, because things can happen, and we are seeing this rising trend in patients, younger patients, but ways to really be an advocate for yourself is trying to, number one, do these annual exams. Just touch base annually with your primary care doctor. But we do understand that these patients, maybe like health insurance is expensive. Going to the doctor is expensive. That means taking a day off of work. So things that actually you can even do for yourself is just go on Google and Google free colon cancer screening, and then insert your city where you live. Because there are a lot of local and community-based centers that either can help out in like stool-based testing, or finding ways to facilitate you getting the screening that you need for either low cost or free. And then a lot of these places are open on the weekends too. So I think that there are a lot of things that young adults have their mind on, which I completely understand. Working a full-time job, either starting a family or having a young family, it takes a lot of time. So I think being an advocate for yourself, ways to do that is just looking for your resources. And at the end of the day, I always tell my patients, especially the younger ones, you can't take care of your family or take care of others around you unless you take care of yourself first.
Put on your mask first, huh?
Great, thank you. So here's something to keep in mind. A patient eventually diagnosed with stage 4 colon cancer at 32 years of age shared her story in a Self magazine article, saying that her symptoms were first thought to be related to anxiety, and it was suggested she seek help from a mental health professional. She also thought it might be a gluten or dairy intolerance. So is diagnosing colorectal cancer in young people difficult? And why is that? Who would like to start?
Well, it's that it's less, it's not as prevalent on their minds, and it's not necessarily something that young people or even, the physicians that are seeing patients like that are necessarily putting as the number one. We talk about in medicine differential diagnosis. So what may be the cause of the symptoms that the patient's experiencing? So, that patient, so like you mentioned, like a gluten intolerance or something that may be more common or more frequent in the younger patient population, like her. And so colon cancer may be a little further down. So it may be a matter of really looking at the most common causes of these patients' symptoms and identifying those and working your way down to figure out the diagnosis. And sometimes that may take time. And that goes back to what Dr. True mentioned about patients advocating for themselves and, knowing when something doesn't quite feel right.
Yeah, absolutely. I mean, it's such an unfortunate story. And I think that a lot of other people have very similar stories where, they develop symptoms, and it's, I don't want to say it's not necessarily taken seriously, but maybe like what Dr. Booth was saying, I don't think of colon cancer immediately when I'm talking to a 30-year-old patient. However, it's unfortunate that she was found to have such advanced stage cancer. And Dr. Booth had touched on it before, know your body. And the story really truly highlights being an advocate for yourself. So, truly just continue to push. And if you have these symptoms, like, don't settle for saying, oh, it's just something in your mind. That's, truly, truly unfortunate. But at the end of the day, it sounds like she was really advocating for herself and really, trying to figure out an answer for her symptoms.
Yeah, I think that story really shows how you just have to be persistent sometimes and don't be distracted. As you both said, you know your body best. And if things are not right, you really have to be persistent. That story really brings that to life, I think. Mm-hmm. So you've already talked about how GI pathologists and gastroenterologists work together. So can you elaborate a little bit more about how your two medical specialties work together to prevent colon cancer?
Sure.
Oh, sure. Yeah. So, whenever I do a colonoscopy, I remove these polyps, and it sounds as easy as, oh, I just remove the polyp and I send it to Dr. Booth to take a look under the microscope. However, there are times where, especially in my subspecialty, where I remove larger polyps. So did I get all the margins well enough that, I don't have to bring back the patient sooner rather than later. And that's when I call him and I say, hey, did I get a clear margin? And that means, is there polyp tissue or precancerous tissue still within the margins? Did I leave any behind? A lot of it just is really talking to Dr. Booth and his colleagues really to figure out if I did my job well enough. And if, let's say, by any chance there is some polyp tissue that was left over, then I know that I can call the patient back and say, hey, instead of waiting for a few years, I may have to bring you back in a year because, at the end of the day, last thing I want is for the patient to have to develop anything in the meantime. And that's where talking to Dr. Booth and his colleagues are really important to really figure out the best plan for our patients.
Yeah, Dr. Booth, what do you think about this partnership? Yeah.
Yeah, it's critical. Just like working with any other physicians. As pathologists, we're kind of oftentimes kind of the behind the scenes physician. Working with more of the other physicians rather than with the patients directly ourselves. So but we do that with all the specialties, really. But it's really it's the only way to make sure the patients to get good patient care, really. So, we look at the polyps that we get. So say I get some neoplastic polyps or adenomatous polyps that may be precancerous. Say there's an area that I'm really worried about. Maybe this area might be cancer. I'm on the edge of it. So, I'll pick up the phone. I talk to the gastroenterologist. I try to identify. I talk about, what did they see? How did it look to them? Whenever they removed it, how did they remove it? What tools did they use, maybe? And then did they felt like they see it all? Because it looks like, maybe to me, it looks like they got it all. I want to convey that to them, or vice versa. And so we may, have that discussion with the gastroenterologist. That may also include a colorectal surgeon or something too. So maybe that maybe they did have an early cancer, an early adenocarcinoma or colon cancer. And the question is, do they need to go back and look at that area like a colonoscopy with Dr. True? Or do they need to have a surgery or something like that, or some other sort of treatment?
Great, thank you. Very important partnership, certainly for the patient. So we talked a little earlier about a risk and maybe how family history might impact risk. So if you have a family history, when should you have that colonoscopy?
Right. So. So family history, yes, we use that term, but it's really, we call it a first degree relative. So a biological mom, dad, brother, or sister. So if one of those have colon cancer in the past, usually we want you to have a colonoscopy 10 years before your family member was diagnosed or at the age of 40, whichever is earlier. So as an example, let's say your father had colon cancer at the age of 39. So if your dad had colon cancer at age 39, you should really be having your colonoscopy at 29. Or let's say your dad had colon cancer at 49, then your colonoscopy would be at 39. So it's really important when we talk about either your brothers, sisters, mom, or dad. If you have what we call second degree relatives, so cousins, aunts, uncles, grandparents, it depends on the number of them too. So that's something that you would definitely sit down with your primary care or gastroenterologist, and just really, it's important to document, who in the family has colon cancer, at what age, because it really then changes the reason why, when you should be getting your first colonoscopy. And so it gets a little bit more nuanced there. So I think it's always good to talk to your primary care doctor.
Great, thanks. So besides family history, let's discuss colon cancer in the African American community. African Americans have a higher risk of being diagnosed with colon cancer and a higher risk of dying from it, whether or not they have a family history. Can you elaborate on that a bit? Dr. Booth, you want to start?
Yeah, African Americans are there's some disparities there, and they're greater than 20% higher risk of of being diagnosed with colon cancer, and 40% risk of dying from colon cancer. So there's a healthcare disparity there, and there's an issue with some of that is with access of care. Dr. True?
Yeah, I mean, it's such a big topic, because health disparities is just such an issue across our nation, across the world, and colon cancer screening isn't reaching a lot of our patients. And Dr. Booth had mentioned that is increasing access. And I think that's one component of several factors as to why these health disparities are occurring. And I think that we've highlighted a lot now in our studies, and this exists. Now, what do we do about it? Because I think that's more important. Like, we know these health disparities exist, but what can we do? And there are some good studies out there on successful programs that, increase access, increase financial support, increase education. And what's more important is really to tailor and create these programs that really are in a true social and cultural context, because we can't just blanket a type of program for everybody. It really does have to be tailored to that specific population.
Thank you. I'm very proud of the fact that the College of American Pathologists is currently working with other organizations, the federal government, and multiple state governments to eliminate health disparities, not only in the African American community, but frankly, in all populations. We view this as a very important part of our work as physicians. So, like with everything, a generally healthy diet may help reduce the overall risk of developing colon cancer. There are actually studies going on right now to try to prove this. In general, it's just better that we pay more attention to what we eat. Change, we know, doesn't come easy, but let's talk about a bit about what we can all do in terms of our diet that can contribute to cutting those odds. Dr. True, you want to start us off? What do you tell your patients about making dietary changes?
Yeah, I mean, you touched on it, Dr. Karcher, with lots of studies going on right now on looking at dietary changes. Right now, there isn't true high quality evidence yet to say, for me to tell patients, like, you should eat this versus that, or, certain products will reduce the risk of colon cancer. But I do say a overall healthy diet that consists of whole grains, dairy, high fiber foods, just really fruits, vegetables, like legumes and beans that are like high in protein. Things that we should really avoid is canned foods, boxed foods, microwavable foods. So those are kind of like heavily processed foods that may not be as healthy for the colon and the GI tract or your body in general. And then we always talk about red meat in moderation. But these are types of dietary recommendations that we talk about in clinic to reduce your risk of colon cancer. Of course, we have patients who eat really healthy and they can still develop colon cancer. So it's not 100% preventative, but I think it certainly reduces your risk. Lifestyle changes too. I think you had said something about
Yeah,
that.
watching the alcohol intakes, decreased smoking, exercise, kind of those things we think of as healthy activities, right?
Yeah, great. That's very helpful. From your perspectives, what do both of you feel are the most important things younger adults can do to reduce their risk of colon cancer?
Well, I think going back to what I said earlier about listening to your body, if you feel like something's not quite right, follow up on that. So don't just brush it to the side in the busyness of life.
Yep, great. Dr. True?
Yeah, I echo that definitely. My perspective is getting screened, and that's just probably because that's what I do. But I really think that getting screened for colon cancer is just what you need to do to prevent it. We have a lot of tests out there that can, screen for colon cancer, but really a colonoscopy is the only thing that you can do to prevent colon cancer by removing these polyps. And so I think that that's probably my biggest takeaway point from today.
Yeah, great. And, a lot of the things that we've talked about, it's a bit complex. So I would just add to that, work with your doctor to do what's best for you to prevent this terrible disease. So thanks to both of you for your expertise. We'd now like to take some time to try to and answer some of your questions. So our first question from Kerry: does the size of the polyp removed during the colonoscopy mean it is more dangerous or likely to be cancer? So who would like to start with that one?
Yeah, so if you don't mind, I'll take this one first.
Sure.
So during a colonoscopy, we do estimate the size. I say estimate is because, when we're in the colon with our camera, the size of the polyp, something I may say looks like a centimeter, another person may say looks like a centimeter and a half. It's, that range seems a little bit big, but, depending on the size of it, we do say anything from 1 centimeter and above, actually, we call it an advanced polyp, because the bigger the size, that means it has more time to grow, more time to have changes towards cancer. And so it is a higher risk polyp. So overall, that does increase your risk of colon cancer when we do find these larger polyps. But the great thing about them is that if I remove them, then it's no longer a risk. Getting into more nuance, the larger the size, then going past 2 centimeters, 3 centimeters, of course, those carry higher risk as well, not only for colon cancer, but also for it to grow back. And so I hope that answers your question. That does increase your risk.
And that's going to dictate, some of those sizes is going to dictate when their next screening colonoscopy will be, right?
Absolutely, yeah. So the larger the size, we tend to bring you back a little bit sooner for surveillance of the polyps to see if your colon potentially means that your colon may be producing more polyps than normal. And so we want to make sure that we catch them before it gets too big or before it advances to something else.
Good, thank you. So we have another question, this one from Mary Catherine. If a patient tests positive for a genetic mutation for colon cancer, how might they be monitored? Does that involve more frequent colonoscopies? What else? What additional things might need to be done for a person like that?
Absolutely, that would involve increased colonoscopies. That may involve starting their screening colonoscopies at a younger age. Kind of going back to some of what Dr. True mentioned about patients at increased risk, because they are certainly obviously at an increased risk. So starting their colonoscopies at a younger age and then increased frequency as well.
Mm-hmm. And it depends on the genetic test too that you take in, if there's a genetic syndrome that runs in the family, it may actually determine, yes, when your first colonoscopy would be. And then also frequency. So it may be every year, maybe every couple of years. Again, it seems kind of daunting to have this, have a colonoscopy and to do the bowel prep every year. But of course, when you have these genetics that increase your chances of getting colon cancer, I mean, it may be a personal opinion, but I'd rather do the bowel prep and do colonoscopy rather than get colon cancer. So I think that knowing your risk and then being, we mentioned before, advocate for yourself and talking to your primary care to figure out the best plan for you.
Great. Yeah, that's very helpful. If a person gets discovered with one of these genetic syndromes that may put them at higher risk. So here's another question from a viewer. What if I don't go to the doctor or have health insurance? What else can I do?
Yeah, absolutely. I mean, we do see a lot of patients without health insurance, but there are so many free programs out there, actually. So again, comes down to there's only so much, you could really, you should really try to advocate for yourself by looking on free programs online. So I've done it before for patients as well, where I would just help them Google colon cancer screening without insurance and then insert city there. These are ways that I found patients in the hospital or even in clinic where they just visit me, even though they're self-pay, that I would help and try and find resources for them. But it's really just trying to, Google is actually a great way of just really trying to search, resources for you in your community. And that's a really good, way of trying to find, resources in order for you to get your screening and healthcare as well. There's lots of great local and community programs.
Yeah, you mentioned about not having a physician. Oh, sorry, Dr. Karcher, go ahead.
No, please finish.
I was just going to say, you mentioned about the, establish, or you don't have a physician maybe. So, looking up some of those free clinics or urgent care, or not urgent care, but those clinics that you can, easily get into to really establish care with someone and kind of get the ball rolling is important.
Yeah. I mean, I think the important thing is don't let life circumstances like no insurance or maybe not even having a regular doctor be a barrier to you getting what you need to prevent this disease, for sure. So here's a great question. What if I have, from one of our viewers, what if I have a family history? Does that make a difference when the pathologist is looking at my polyp? Is it important for the pathologist to know that?
It is. It's not going to change my diagnosis. Like if it's a tubular adenoma, or a dysplastic polyp, it's a dysplastic polyp. But, knowing that if you have a history, you may be at a more increased risk. So that may be something. So say I diagnose so many polyps, I may mention a comment there. I may say something, convey that, kind of going back to how we have conversations with the gastroenterologist, convey that to the gastroenterologist about this patient. Maybe they seem to be, they're producing a lot more polyps, seem to be at an increased risk. So they maybe need genetic counseling or testing to determine if they're at, their family members might be at an increased risk as well.
Mm-hmm. And you mentioned earlier when you're looking at underneath the microscope that sometimes it's not clear cut, right? Does that affect if the colon if there's a colon cancer that runs in the family or they have higher risk? Does that affect your decision making at all?
Sure. I may if they have an increased risk, I may, say I'm not seeing polyps or I'm not seeing anything dysplastic. I may push a little bit more, or try to look at some more tissue or a little bit more extra slides to see if I can, identify anything that might make sure that they continue to get screened or that they're at increased risk. Yes. But in some polyps, there are a few of these kind of syndromes where some of the polyps can look a little bit different, but that can be, much into the weeds.
Yeah. So like all physicians, it's really important for the pathologist to have as much information about the patient as possible. Very helpful to us when we're doing our work to make diagnoses. So, we've talked a good bit about colonoscopy. Here's a question from one of our viewers. Where do tests like the home test Cologuard fit in? That's, of course, a test that looks at a stool sample, looking for DNA abnormalities and looking for blood in the stool. Is a pathologist involved in screening those results? This is what our viewer would like to know.
So those are put on. Some of those tests are been developed by a few different companies, looking at altered DNA for dysplastic or cancer already. So not necessarily preventing the colon cancer, but more screening to see if it's there already, or at least a pre-colon cancer is there already. And so those tests, once performed, would go to a laboratory that a pathologist would be overseeing, and they would see those results as they come out. But that would be differently than you would have kind of what we've been talking about with the colonoscopy and actually taking tissue like the gastroenterologist does.
Yeah. And just to add to that, these home stool tests are great too. And so there's two strongly recommended ways to screen for colon cancer. Number one is your colonoscopy, which we've talked extensively about, but it does, of course, require a day off of work. It requires a bowel prep. It requires someone driving you that day because you are getting some sort of medications to keep you asleep during the procedure. And then there's the other strongly recommended annual stool test takes a look at traces of blood in your stool. And so those are the two main ones. One of our listeners had mentioned Cologuard, which then looks at altered DNA, like Dr. Booth had mentioned, that may be coming from some sort of precancerous or cancerous growth. It also looks at trace blood as well. And so those are recommended, to be taken every 3 years. It's not, the evidence isn't as robust because, of course, it's a more newly developed test over the past decade. But these are also options. And at the end of the day, in our field, we say any screening is better than no screening at all.
Yeah, so lots of options, but do what's best for you, but do it, I guess would be the take-home message. So go ahead, Dr. Booth.
Oh, sorry. Yeah, just to follow up on that. So if a patient, just to Dr. True, so a patient, they do one of those at-home tests and it comes back as, potentially a cancer. What happens then? Can you
definitely have to get a colonoscopy at that point. So any stool test that comes back as positive, you should be getting a colonoscopy because something is abnormal. Now, it doesn't necessarily mean, and just to put you at ease, a positive stool test doesn't mean that you have cancer. It's in order for us to really take a look. It could mean that you have an advanced polyp. It could mean that you have, it takes a look at trace blood too. So, sometimes hemorrhoids, like large hemorrhoids that are bleeding, that can also cause a positive test as well. But either way, I think that if any stool positive or stool test is positive, our next recommendation is always going to be a colonoscopy to make sure that there isn't anything in there.
Great. Thanks for adding that extra bit to that answer. So another question from one of our viewers. Are there any misconceptions about colon cancer? My friend was told that it might be irritable bowel syndrome, IBS, or food allergies, but it was colon cancer. This sounds a bit like that Self magazine article that we quoted earlier. Can you comment about this? Misconceptions, IBS, can IBS be confused with colon cancer? And can food allergies be confused with it?
There can be some overlap there with the symptoms. So like IBS, for example, patients may have, chronic constipation or chronic diarrhea. In a patient, maybe they have a large colon, a mass or a cancer, for example. One of the symptoms is constipation because it's in the way, right? So it's obstructing. So, there's some overlap there with symptoms that the patient may experience, just kind of like Dr. True mentioned about hemorrhoids, with some blood from hemorrhoids versus maybe some blood from a tumor. So there's some overlap there. So that's why it's kind of going back to communicate with the primary care physician or the gastroenterologist what's going on so that you can kind of weigh those out and that, like we talk about our differential diagnosis, what's actually causing this patient's problem. And so how we can kind of check things off as far as, rule them out. It's not causing that. It's not this. It's not this. This is the most likely thing. And we proceed from that.
Yeah, I 100% agree with that. I mean, you can have these overlapping symptoms. So again, not all colon cancers will present with symptoms such as those. Not all IBS is going to be colon cancer. But at the end of the day, I think that getting evaluated with by your primary care doctor and your gastroenterologist to really narrow down, your symptoms and hone down on what could be causing them, and ruling out colon cancer is always a big advice I give to patients, and comes back down to advocating for yourself, really knowing your body, talking to your healthcare providers as well.
Yeah, great. So here's a great question. This viewer has been reading the newspaper. I heard about a new blood test that's being studied to screen for colon cancer. What are the pros and cons of tests like this? This is something that I know was very recently talked about in the newspaper. Can you all comment about what we know about that test.
Absolutely. Do you want to start off? Or?
Sure. So that test is looking at circulating DNA in the blood. And that, like you said, it's recently come out, and studies are early on, but it's very promising as a potential screening tool. But currently, it's picking up, already cancer, right? So that's one thing that separates that from like screening versus, almost like diagnostic, right? So it's still early on, so it's not to the point of colonoscopy, the real gold standard here, but it's it's exciting. The technologies like this for non-invasive real methods of evaluating for colon cancer are coming out. And Dr. True, I know you have more.
Yeah, I mean, it's really exciting because it just really increases our tools in order to get patients screened. And so this study was just just released this past week, and it's been making great headlines, which I'm so excited our viewers are reading. And really to ask more about your primary, with your doctors about. But what it really is that it's going to allow us to reach patients who don't want a colonoscopy or are fearful of a colonoscopy, or maybe they're not the healthiest person to get the colonoscopy, but it just increases our ability to screen and reach patients that we're not able to right now. And so it certainly, as what Dr. Booth said, it doesn't replace the colonoscopy, because a positive blood test will then lead to a colonoscopy anyways, but it's a fantastic adjunct, to our tools of just getting our patients screened. And again, I will say, getting screened in any way is better than not getting screened at all. So I think that this is going to be a great test to really add to our big, our methods of being able to get patients screened in any way for colon cancer.
And there's patients that just the whole colonoscopy, all of the stuff that goes with it, they just won't want to do, but maybe they're much more amenable to a blood draw.
Yeah.
So hopefully, things will develop further in that way, so we can increase our screening rates.
Yeah, hopefully the technology is going to keep getting better and better, and that will give us even more tools to hopefully prevent more people from getting this disease. So that's all the time we have. I want to thank you very much for tuning in. I also want to thank Drs. True and Booth again for joining us today and for providing great information for our viewers. This live stream will be available to watch again on the College of American Pathologists YouTube channel and in the CAP newsroom. Remember, you can get screened for colon cancer and it can be prevented. Be an advocate for yourself and for your family members. Also, if you ever have any questions about your pathology report or lab test results, we encourage you to call the lab and ask to speak to the pathologist who oversaw your tests. Pathologists are there for you as part of your healthcare team. If you'd like to learn more about pathology, please go to yourpathologist.org. We have a series of videos available there where we answer the most common questions about diagnosing colorectal cancer, cervical cancer, and skin cancer. You can also find out about what blood testing reveals about your health. Again, I'm Dr. Donald Karcher, and on behalf of the College of American Pathologists, we'd like to thank you for joining us today.